Hello everyone, welcome to today's session. This is Outpatient Hysteroscopy Guidelines, GTG 59. So we are going to talk about this new guideline. This is the updated version and hence it is very important for the current exam. So it is important for all the parts, part 1, part 2 and part 3. Part 2 students can expect good number of questions, EMQs from this, and the part 3 ones can go ahead with the consent stations, which could be the most important one. So I'm covering the guideline as per the requirement of all the parts. So it will be beneficial for you all, right? So here we start with the guideline, Outpatient Hysteroscopy Guidelines, that is GTG 59. So first, let me start with the introduction. So outpatient hysteroscopy is an essential diagnostic and the therapeutic procedure widely used across the UK. The procedure involves the use of miniaturized endoscopic equipment to directly visualize the uterine cavity without the need for intravenous sedation or regional general anesthesia, necessitating the use of formal theater facilities. So actually what they are going to do, why they are putting up these guidelines and these things recommendations? Because outpatient hysteroscopy we know is a very important procedure, and which is like a diagnostic procedure can be done in an outpatient setting and we can get a very good amount of information, and therapeutic things can also be done on the outpatient basis, right? So how does this help the patient? First thing is, it's a short procedure, outpatient, so patient does not have to stay in the hospital. Secondly, patient is very comfortable if something is done outside the operation theater. So therefore, this is recommended by the guideline that the outpatient hysteroscopy should not be conducted in the formal operation theater. Because if you do so, the purpose of doing the hysteroscopy is largely defeated. So you want to stay outside the hospital, and of course it's a minimally invasive surgery. That is always the advantage, but it becomes comfortable and the patient's experience becomes better if you do it outside the operation theater. So they recommend that there should be a separate, well-equipped, appropriately sized staff treatment room where adequate private changing facilities and the toilet is there, and this may be a dedicated hysteroscopy suite or a multi-purpose facility. Now, what are the consent requirements? That is the very important thing, because we have to take the consent, and what things we have to take. The discussion of the alternative pain management. See, whenever we are doing the hysteroscopy, we are not giving any anesthesia, right? We are just giving the non-steroidal anti-inflammatory drugs 1 hour before the procedure. In next few slides, I'll be talking about the pros and cons of this. But whenever we are taking the patient for the hysteroscopy, we should always give her the alternatives also, because she might be anxious of doing this in an outpatient basis without anesthesia, and she may choose to be the have some other mode, right? So some other mode like the general anesthesia, or she may require the cervical anesthesia. So these can be required. So basically, what we have to do is, when we are counseling the patient for the consent, then we have to discuss the alternative pain management pathways. What are the indication? What is the indication for the patient? That should be appropriately mentioned, and she should be counseled. What are the additional procedures? If at all we are required to do any additional procedures, then we have to explain those as well. And what are the risks and the benefits of this procedure? This is another important thing which we need to talk about in detail. And the exclusion of pregnancy. This is a very, very, very important point. Asuji loves this point, and yes, this is a very, very important safety point. So discussion of the alternative pain management, indications, additional procedures, risks and benefits, and exclusion of pregnancy. These are the important points which we need to talk about when we are going for the consent requirements. So part 3, people, if they are going to get the consent station, then they have to explain all these things in their station, and this will formulate the content. Pre-procedural analgesia, as I said, is a very, very important, because that's a very important thing. Here we have to see that the patient is adequately comfortable and relaxed. So we have to choose the analgesia according to that. And what is the recommendation? We are going to talk just now in the few slides further. And secondly, we have to see that the patient is so much conscious that she can go home early, right? So both the things needs to be balanced. Discuss about the probability of the cramps or the lower abdominal pain, which can be seen either during the procedure or largely in the post-procedure period. So these are the important points to be discussed. Now, what about the pre-procedure safety checklist? Safety points, very, very important. Patient identity. You need to check the correct patient. Drug allergies is a very, very important point. Exclude pregnancy, right? So how to exclude? You can do the urine pregnancy test, right? If patient is in doubt, or you think that it's quite early and you will not be able to find the pregnancy test, then we have to counsel the patient accordingly. If she chooses to go ahead with the hysteroscopy, taking the risks, then that's fine. And if she wants to postpone, then we need to postpone the procedure because of that reason. Because we are not able to do the pregnancy test, or we think that the pregnancy test is not a good option at this particular time because it's too early. We may not get a good test report. All consent discussions, which I have included in the previous slide, they should be discussed, right? If you miss something, then you lag on the safety points. So these are the two slides, very, very important for the part 3 people. Now coming to analgesia. As I've already mentioned in the previous slide, the pre-procedure analgesia, that's a very, very important thing, and we need to take care of that. So analgesia, when we talk about, what is the recommendation for analgesia? So oral non-steroidal anti-inflammatory drugs 1 hour before their scheduled appointment. So oral non-steroidal anti-inflammatory agents 1 hour before their scheduled appointment, right? So this is the one which is the main recommendation, and this has shown the maximum benefit of reducing the pain for the procedure. We are more bothered about the pain and the vasovagals. Vasovagals, we don't have enough evidence which one is reducing, but non-steroidal anti-inflammatory drugs has the best effect on these things. Now, there are some contraindications where we cannot choose the non-steroidal anti-inflammatory drugs. So what are those contraindications? So if the patients are asthmatic, or the woman has a renal impairment, or there is a gastric ulceration, or she declines this for any reason, right? So either she is asthmatic, or she is having the renal impairment or gastric ulceration, or she is declined. So what is the next possible option for us? So if the non-steroidal anti-inflammatory drugs is not the drug of choice, then the next possible thing we can do for the patient is doing the TENS. TENS has a very good effect and has shown a very good evidence. But what's the problem? Why we are not making it first line? The problem is that it is actually not available at the sites all along. So TENS or oral opioids or antispasmodic drugs. Antispasmodic drugs like hyoscine, that is the buscopan. So these types of drugs. Now TENS is the safe. What is the problem with the oral opioids? Why we are not preferring it as a first line? Because of the problem of dizziness. Then comes the second thing, that is the antispasmodics. It is also not the first line. So what is the cause of that? Because it has seen to increase the evidence of the vasovagal episodes. So therefore, we are not preferring them as a first line. We can just prefer them as a first line if at all the other drugs are not suitable. Other important thing which we can take around is the Entonox, that is the mixture of 50% nitrous oxide and 50% oxygen. So Entonox, equimolar gas, mixture of 50% nitrous oxide and 50% oxygen. Penthrox, methoxyflurane, this is another very good, very quick acting, the inhalational analgesic agent. which can be self-administered, and it is largely used in the trauma. But this is seen to be effective largely in the post-procedure analgesia and does not have a very good effect in the intra-procedure analgesia. Now, something about the cervical preparation. So what we need to do is in the cervical preparation. So no routine preparation is required, right? So no routine preparation is required ideally. If required, we can use the vaginal prostaglandins, right? So if at all it is required, then we can use the vaginal prostaglandins. Now, what about the prostaglandins? What is happening here? The misoprostol and the dinoprostol are the two drugs which are found to be effective in this case, while carboprost, we do not have evidence to support this, right? So misoprostol 200 micrograms and dinoprostol 3 milligram are considered to be safe for these patients. Now, they can be used, but they are also not used routinely. As I said, cervical preparation is not routine. So what are the indications when it needs to be considered? So it needs to be considered when you are anticipating that patient may have cervical stenosis. So when will you anticipate that patient will have a cervical stenosis? The possible scenarios could be patient is previous cesarean, or simple nulliparous women may have a difficulty in passing through the os, atrophy, or there could be other causes, any surgeries on the cervix. So if you are anticipating that you will find the cervical stenosis, so in this case, you may need the cervical preparation beforehand. And remember, cervical stenosis is the main and the most common cause of failed hysteroscopies, right? So this is the main and the most common cause of failed hysteroscopies. Now, sometimes you may need to take a hysteroscope with a bigger diameter. So there is need to dilate the cervix beyond 6 millimeter to accommodate the uterine instrumentation. Now, when to get the cervical preparation? The older version of the guideline used to say that we have to do the cervical preparation 3 hours before, right? But in this case, it is done 12 hours before the procedure. The new guideline recommends that we should do this medication. If we need for the cervical dilatation, we should do it at least 12 hours before the procedure. Now, what are the risk factors for the uterine trauma? So we said there are two main complications which we see with the hysteroscopy. One is the uterine perforation and another is the cervical injury. So for cervical injury, we just talked of that we can take care of looking at the patients who has the possibility of cervical stenosis. But what are the risk factors for the uterine trauma? The blind dilatation beyond 6 mm for intrauterine instrumentation. Example, for the use of large diameter operator hysteroscopes. Here, if you are doing the blind dilatation, then of the larger diameter hysteroscopes, that is the 6 mm, then this could be the possibility. Again, if you are handling the uterus with the cervical stenosis and you are pushing the dilator or you are pushing the hysteroscope with a force, then again the problem is going to may come, right? It's not always, it might come. A tortuous cervical canal, disfigured, right? So it is because of the association of the fibroids, could be one of the example. Deviated uterine cavity, which can be in the acute flexion, pelvic adhesions, and the fibroids. So deviated uterine cavity. Now, what are the sizes of the hysteroscopes we prefer? So we are doing two types of procedures. We are doing the diagnostic and we are doing the hysteroscopy. So hysteroscope, diagnostic and the therapeutic. Sorry, it should be diagnostic and the therapeutic. So in the diagnostic, we are using the ones with a thinner diameter. That is 2.9 mm, 3 mm or up to the 3.5 mm. So as you see in the upper picture, this you see as a thin hysteroscope, right? This is used for the diagnostic purposes. This one, thicker one, which is 5 mm, 6 mm, it has the working channel. And they are the thicker scopes. And we use them for the operative purposes. Now, what about the lenses? We can have a 0 degree where we go directly straight. You see here, you are going directly straight and your lens is flat, that is 0 degree. So you can see your area right away there, and it is simply, you can see that, see the picture is directly you are looking at this funnel, right? So you are directly looking straight at it. So this is the 0 degree one. Now, the other one which is tilted. So tilted is the, basically in the tilted, you see that as you are going inside, you are looking at one side, right? So you have a view, but then you can clearly see that particular view and reach up to the corners. And this is important if you are doing the operative one. So 0 degree hysteroscopes are more intuitive, facilitating to the cervical canal. So whenever you are expecting that you are going to face a problem at the level of the cervix because of cervical stenosis, then in that case, 0 degree is the better one, and it will reduce the incidence of causing the injury. It will also minimize the discomfort and the uterine trauma. And of course, as I said, it facilitates the entry into the uterine cavity. Now, if we are taking the 30-degree lenses, then these are the for oblique lenses. They facilitate the visualization of the ancillary instrumentation and so are advantageous for the operative hysteroscopy. Now, there are two types of scopes, rigid versus flexible. Rigid hysteroscopes may provide better images, fewer failed procedures, quicker examination, time, and reduced cost. So rigid ones, they may cause a slightly more pain, but they have better images, fewer failed procedures, quicker examination time, and reduced cost. But this all comes at the cost of slightly more painful. Flexible hysteroscopes are associated with less pain during the diagnostic outpatient hysteroscopy. With less pain, the other things we have to compromise a bit. So we can choose as per our requirement, rigid and flexible. But usually for the vaginoscopy, we are using the flexible ones particularly for the diagnostic purposes. Now, what type of devices should be used for operative procedures in the outpatient setting, right? So what devices should be used for the procedures in the outpatient settings, right? So what is the procedure and what we are doing? So endometrial polyp. It is important that it is recommended that we should use mechanical hysteroscopic tissue removal systems compared to the bipolar devices or the electrocautery devices. Mechanical hysteroscopic tissue removal systems like the shearers are less painful, quicker, and more successful and more acceptable to the woman for the removal of endometrial polyps when compared to using a miniature bipolar electrode. So instead of electrosurgery, we are preferring here the mechanical tissue removal systems. Endometrial ablation, clinical, it is totally on the clinical discretion. What the operating surgeon wants, he can go ahead with that. Uterine septa, there is mechanical mini scissors is associated with less pain than the use of miniature bipolar electrode. So again, the mechanical mini scissors, they are better one as compared to the bipolar electrodes. Now coming to the distension media. So in the distension media, the saline is recommended as the distension medium for outpatient hysteroscopy. Saline is associated with less post-procedural pain, better image quality, fewer side effects, shorter procedural time, greater patient satisfaction, and allows for operative hysteroscopy. Now, because this is isotonic, so it minimizes the risk associated with the fluid overload. And because it is a conducting medium, so it allows the operation of miniature bipolar electrodes to be used. So, therefore, Saline is the best medium to be used. It has less pain, better image quality, fewer side effects, shorter procedural time, and greater patient satisfaction. And of course, with the safety point of view, also it is the best one. Now, what are the pressures we need to use? So we should use the lowest minimum pressure at which the image quality is the best one that we achieve. If we achieve at any particular pressure the good image quality, that is the best pressure for doing so, and we should try to choose the lowest one possible. Now, use of the automated fluid management systems, like setting initial intrauterine pressures at 40 to 50 millimeters of mercury. 40 millimeters of mercury is actually taken to be a good pressure, and for the safety and for the pain, good pain relief as well. Up to 40, patient is comfortable. As we go above 40, the patient feeling the pain, and as we go beyond 50, it is largely painful. So 40 is a good amount of fluid which can be there in the uterine cavity, and you can have a good image quality as well. Rest you can just manipulate a bit up and down as per your requirement. Now this is the one which is minimum needed to obtain a satisfactory view. Automated fluid management systems can be actually can have automatic cutoffs, but if you are doing it manually, then you can manage it by the flow meters. Now, there are certain things which we should not do routinely in these procedures. So what are those things which are not to be done routinely? So one is the routine cervical dilatation. Again, I already said the cervical preparation is also not routine. So similarly, we are trying to dilate it with the instruments. That is also not routine because it will increase the chances of the cervical injury, right? So we don't want to do this. So this is again done, the indication only when done is again the two indications we talked about in the prostaglandins. One is where there is cervical stenosis possibility or where we want to use the larger diameter instruments. The second is the local anesthesia. Local anesthesia, we are just going to talk about a bit more in detail because again in the indications where we are expecting the cervical stenosis, we may like to use the local anesthesia for the relaxation, or where the patient is very much anxious about the pain. So again, we can go ahead with the local anesthesia, but this is not a routine thing to do. Third thing is the conscious sedation, which could be like mild sedation, where patient is awake, but she's not feeling the pain. This could be the oral analgesia, or could be the inhalation, or could be the IV. But this is also not the one which is recommended routinely. So while we are reading what is recommended, it is also important to take care of the points what is not indicated routinely. Now, what about the local anesthesia? So local anesthesia is considered where use of the vaginal speculum is planned. That is where we need to catch hold of the cervix. So where cervical dilatation is anticipated due to either cervical stenosis and or utilization of large diameter hysteroscope. Mepivacaine and bupivacaine were the only agents which are associated with the reduction in the pain during and after the outpatient hysteroscopy. Although trials have been done with the many, like in the last line, you can see we are talking about the mepivacaine, lidocaine, prilocaine, bupivacaine. So all these can be used. But mepivacaine and bupivacaine has shown the clear-cut significant evidence of reducing the pain during the procedure and in the outpatient hysteroscopy as well. Mepivacaine is the only one which reduces the incidence of vasovagal episodes. So here is the one which gives the benefit of the vasovagal episodes. Short-acting local anesthetics like mepivacaine, lidocaine, and prilocaine, they can be in straight 2 minutes prior, while the long-acting ones require at least the 5 minutes to allow for the onset of action. Now, what are the various routes? How we can give this local anesthesia? Either we can just apply the topical. So application of topical anesthesia directly onto the ectocervix, transcervical. Installation of local anesthesia through the cervix via the cannula or within the distension medium. Intracervical, we are injecting directly into the actocervix, or we are giving the paracervical. That is the injection of local anesthesia into the cervicovaginal junction routes were investigated when given in an outpatient setting. So what was the result? So overall, all of them had a significant reduction in the pain. So all was good when we saw the effect, but the maximum effect is seen with the paracervical one. Important point for exam question, right? So maximum effect was seen with the paracervical one. Now, the another important anesthesia, which is also giving good results, particularly tried in the patients with the endometrial ablation, is the intrauterine administration of local anesthesia in the fundus, where you directly apply this in the fundus. So when it is applied directly into the fundus, then it's also giving a very good benefit, and their studies have been carried out in the endometrial ablation procedures, and it has seen to be effective for the pain reduction. Of course, it does not have any effect on the vasovagal episodes. Now, vaginoscopy. Vaginoscopy, what is this? This is a standard technique for the outpatient hysteroscopy. And in this, actually, this is a no-touch technique. So what we do is we just insert the hysteroscope into the vagina with the fluid on. So as the fluid gets accumulated in the vagina, it just forces the os, and with that pressure only the os gets open, and you can directly go with your hysteroscope into the cavity, uterine cavity through the cervix, right? You don't need to dilate it, you don't need to catch hold of it. So it is only the water which is, the saline which is acting as a distension media. It is going and dilating, right? It's building the pressure and it is dilating. So that can only work. So there is no touch technique. We don't have to catch hold of cervix. We don't have to use the speculum or the valsinum to hold the cervix. So therefore, this is obviously significantly less painful, quicker, and associated with fewer vasovagal episodes when compared to the use of a vaginal speculums. Vaginoscopy should still be considered after using a vaginal speculum to administer the local anesthesia to the cervix or the cervical dilatation. If at all we think that there is a vaginal, we can encounter the cervical stenosis, and you want to instill the local anesthesia into the cervix, or you want to put some instruments for the cervical dilatation. So in that case also, even if you are using the speculum, then also the vaginoscopy is recommended. Of course, in that case, it won't be no touch because you have already put up a speculum, already put up a valsinum, but at least you can go through this. It will still be less painful, and it will be easy for you to have a good genital tract instrumentation, and maneuverability of the hysteroscope will be easy. So handling of the hysteroscope will be easy if you go ahead with this. Now, the role of the routine antibiotic prophylaxis. So routine antibiotic prophylaxis is not recommended for outpatient hysteroscopic procedures. Outpatient hysteroscopy should be delayed and the genital tract swabs taken and or antibiotics administered if the pelvic infection is suspected and confirmed microbiological infection should be treated with antibiotics. So there is no role of routine antibiotics prophylaxis is there. But if at all you suspect that there is an infection, then of course you can go ahead with the antibiotic prophylaxis. If a pyometra is diagnosed any time during the outpatient hysteroscopy, antibiotics should be administered immediately to minimize the risk of systemic infection. Because pyometra, you will largely found this in the postmenopausal women where you are suspecting malignancy. So now in these cases, as you put up the hysteroscope, it is a high probability of getting dispersed, right? So because of that, we need to give immediate antibiotics to these patients. Now, how can we diagnose the post-procedure infection? So post-procedure infection can be diagnosed if 2 or more of the following criteria are met in 5 days post-hysteroscopy. If you see these criteria in the 5 days post-hysteroscopy, then you can diagnose it as post-procedure infection. So what are the criteria? There you have to look at. One is fever, the body temperature greater than 38 degrees centigrade or 100 degree Fahrenheit at repeated measurements over the period of at least 48 hours. So if you have taken a repeated measurements and there are still the fever is there, body temperature is high, then that you can take as one of the points or one of the criteria. Lower abdominal pain is persisting. Uterine adnexal and the cervical motion tenderness is there. Purulent leukorrhea, vaginal discharge or itchiness, and dysuria. So fever, body temperature, lower abdominal pain, uterine adnexal or cervical motion tenderness, purulent leukorrhea, vaginal discharge or itchiness, and dysuria. Now, as we have done the procedure, now we need to document the findings. So when we need to document the findings, then what we have to do? So while we are documenting the findings, what are the things we need to document? So these are the notes which we have to make, and in the next slide we will talk about what are the findings, how to put up the findings which you have got for these patients. Okay, so basically the important is that we have to put up who is the operator, who is the surgeon, then hysteroscope, operative device used, including the instrument diameter as a minimum. What was the approach? Whether we did it by the vaginoscopy or by the speculum. Distension media which we used, that has to be added here. Saline, local anesthesia, if at all we used, we need to mention that as well. And when we are mentioning the local anesthesia, we have to mention the agent, the volume, and the route. Cervical instrumentation like tenaculum, cervical dilatation, what at all we are using here, that we need to write here. Biopsy performed, and if so, method used. What is the method by which the biopsy was taken? Operative procedure performed, if any, that also need to be mentioned. If any inhalational anesthesia or analgesic, any sedative used, then we have to mention that. Procedural success and reasons for the abandonment. Intolerable pain, poor visualization, etc. if applicable. What are the complications like vasovagal reaction, uterine perforation, heavy bleeding, anything which happened. So first starting with who was the surgeon, who was the operator, what diameter of the hysteroscope was used, what was the approach, the distension media used, local anesthesia used, the agent, volume, and the route, the cervical instrumentation, biopsy performed, and if so, method used, operative procedure performed, if applicable, use of oral or inhalational medications with analgesic or sedative effect, procedural success and reasons for abandonment, complications, if any, should be mentioned there. Now, what about the documenting the findings? When we have to document the findings, an impression and description of vulva and vagina, cervix and endometrium, all this we need to talk about. So first we will start with the vulva, then go into the vagina, then cervix, and then we talk about the endometrium. So remember, it's not directly the endometrial cavity that we have to talk about. We have to talk from the outside inside. Visualization of both ostia, details of any congenital, that is the hypoplastic T or Y-shaped uterus, septum or other structural anomalies, or acquired uterine pathology like adhesion, cervical niche, fibroids, Figo type 0 to 3 polyps, and retained products of conception. The uterocervical length should be recorded when a global biopsy is taken or an intrauterine device fitted. So these are the various findings which we need to document in our notes when we are talking about the procedure. So that was about the guideline. So now we are going to solve few questions regarding to this guideline to see how it goes, right? So you all can answer in the live chat. So basically, I'm going to ask the questions and you can put up your answers in the live chat. We are starting we are starting your hysteroscopy training module and are shown different diameter hysteroscopes. So which one would you recommend for the outpatient hysteroscopy? So which one would you recommend for the outpatient hysteroscopy? A, B. A is 1.7 millimeters with a 2.7 millimeters sheath, 2.7 millimeter with a 3 to 3.5 millimeter sheath, and 3 millimeter with a 4 millimeter sheath, 4 with an 8 sheath, 4 with for oblique 30-degree lenses. So which one we are going to choose for these patients? Yes, it's perfectly correct. It is B. 2.7 with a 3.5 sheath. This is B is the correct answer. Absolutely. Now, a 43-year-old woman is attending the outpatient hysteroscopy service for investigation of intermenstrual bleeding. She has no medical problems and she is concerned about the level of discomfort following the procedure. Which of the following is suggested routinely? Right, so we are talking about the level of discomfort for the because of the procedure. So which of the following is suggested routinely? Use a non-steroidal anti-inflammatory drug 1 hour before the procedure, or use a routine opiate analgesia and cervical dilatation, prostaglandin administration, or conscious sedation. So the one which is most preferred is, yes, everybody is right. This is use of non-steroidal anti-inflammatory drugs 1 hour before the procedure. That is the maximum evidence and that is the one which is recommended. Now, with respect to instrumentation of the uterus, which operation has the highest risk of perforation? Right, something beyond the hysteroscopy, but yes, it's an important question. So, which of the following procedures will have a maximum risk of perforation? Division of intrauterine adhesions, outpatient hysteroscopy, postpartum suction evacuation for hemorrhage, second generation endometrial ablation, and surgical termination of pregnancy. Yes, you are correct. It is C. Postpartum suction evacuation for the hemorrhage. This is very, very important procedure where we can have a risk of perforation because there is a postpartum uterus. It's bigger in size. It is soft. So the perforation risk is highest in this. Now, SBA 4. 62-year-old is due to undergo a hysteroscopy due to the thickened endometrium detected as part of her investigations for postmenopausal bleeding. Which medication should be used to prime the cervix prior to the hysteroscopy? So which medication should be used to prime the cervix prior to hysteroscopy? So here, what we use to prime the cervix? So what we talked about in the guideline, we do not use anything to prime the cervix routinely. So, and we don't see any risk factor here too. So basically, what would be the correct answer? That no medication is required. Okay. So next question, a healthy 54-year-old lady is due to attend the outpatient postmenopausal bleeding hysteroscopy clinic. Which medication should be advised to consider taking prior to her attendance at the clinic? The 54-year woman is going to attend for the postmenopausal bleeding hysteroscopy clinic. And which medication should she be advised to consider taking prior to her attendance to the clinic? So we know that what is the pre-op preparation? We use only one drug for the pre-op preparation and that is non-steroidal anti-inflammatory drugs 1 hour before the procedure. So B is the correct answer. Here is the another question that is SBA 6. So you see a 5-year-old para 3 in your outpatient hysteroscopy clinic. She wants to be sterilized and undergoes hysteroscopic sterilization during the assured device. What post-procedure device advice will you offer her? Backup contraceptive cover for 3 months, contraceptive cover for 1 month, backup contraceptive cover is unnecessary, tubal occlusion should be confirmed in 6 weeks, and a tubal occlusion confirmatory test is unnecessary. So yes, whenever we plug the tubes with the Assure, we have to wait for 3 months. We should use the 3 months backup plan. Why? Because it takes time for the fibrosis to occur and tubes to get blocked. So backup contraceptive cover for 3 months is the correct answer. So that was about the session of the outpatient hysteroscopy guidelines. Please let me know in the live chat and in the comments below, like how did you find this session so that I can arrange more of such sessions. If any particular guideline you think that is tough and you need help, you can always let me know and I'll be happy to share the videos like this. And if you want to get the videos, all such videos for complete course, and along with the summaries of all the guidelines, then you are welcome to join our part 2 course with the unlimited access. And of course, if you have not decided when to appear for the exam, still this is the best because we have access till past. So I hope you enjoyed the session. So here, if you like this video and you find this video helpful, because it was a summarized content, then you can have such videos for all the guidelines. That's a part of our course. So MRCOG Part 2 course with unlimited access, you can always get that. And as you can see, you even don't have to decide whether when you are appearing for the exam, whether you are appearing for the January, July, you don't have to decide. You just have to join and then your access is till you pass. So that is also there, and it includes everything like revision, the recalls, library access, everything. And similarly for the MRCOG Part 2 course, also we have everything you need to pass for Part 3. The templates are there, the videos are there, so everything is there. And these are the details of our full course and the crash course. So you can see the full course have access till you pass and everything you can see here. And the crash course, it has access till the exam. So whichever is suitable for you, you can just go ahead with. And if you want to like enroll, these are the QR codes which you can scan and just go ahead with that. If you are looking for Part 3, you can just text us on our number or on the mail, and here is the website link where you can go and check the reviews, and also you can go for that. If you want to discuss your exam preparation, then this is the meeting link. Here you can just scan and book your meeting with me. I'll be very happy to help you through your exam preparation. Many of our candidates have done just complete MRCOG in 1 year. So if you are looking to do that within 70% less study time, then MRCOG courses is the right place to be here. So why to be afraid? Enjoy the game, chase your dreams, because dreams do come true. Particularly when you are in the MRCOG courses by Bhawna Khera. Thank you so much for your patient listening.